Welcome back to PedsCrit. I'm Zach Hodges, a pediatric ICU fellow from UT Southwestern in Dallas.
And I'm Alice Shanklin, a critical care fellow at Children's National in Washington, D.C.
Today, we're excited to jump back in on part 2 of all things extracorporeal liver support. In this episode, we really talk about the nuts and bolts bedside approach, or how this is actually implemented at our guest institution.
Yes. Today, we have Dr. Ayse Arikan. She is the Associate Research Chief of the Division of Critical Care Medicine at Texas Children's Hospital and an Associate Professor at the Baylor College of Medicine. She is not just a clinician-scientist, she also serves as the Medical Director of Critical Care Nephrology and Inpatient Dialysis. And she's the Medical Director of the Extracorporeal Liver Support Program there at Texas Children's. We are so excited to share this piece with you. She is a fountain of information.
Yes, I learned so much. Let's get right to the episode. Done a great job unpacking some of the didactic components of this therapy. I wanted to perhaps zoom in on your practice and your center's practice just to maybe give our listeners a little bit of an example or understanding of how this is being implemented at your center. So maybe how do you define clear indications and maybe contraindications for extracorporeal liver support at your center?
Yep, great. So the first step is trying to tease out whether a patient has acute liver failure or acute on chronic liver failure, because our approach is going to differ just a little bit. So let's say we have an ALF patient, just like in our vignette. Every ALF patient is going to be assumed to be a transplant candidate in our center. Because they're possible transplant candidates, we will evaluate them for possible need for extracorporeal liver support. If a patient has hyperammonemia, AKI, fluid overload, relative oliguria, worsening oxygenation due to inability to handle additional fluid that is required, such as excessive blood product transfusion, any of these are going to be indications for CRRT. Hyperammonemia in our institution is defined a little bit differently and maybe a little bit more aggressively. So we do use a lot of medical treatments, such as rifaximin, etc., in order to control hyperammonemia in patients. But if a patient has an ammonia level that is rising, despite maximal medical therapy, we can pull the trigger for CRT even with ammonia levels as low as 60. If somebody has, given the trajectory is in the wrong direction, because chances are next ammonia check, it's going to be 90, next ammonia check, it's going to be 120. If somebody has ammonia greater than 150, we would consider that an absolute indication, provided all of the medical management is in place. Hepatic encephalopathy of any degree potentially puts the patient as a candidate for augmented clearance. And that might be TPE, that might be TPE plus TPE and or MARS. Depending on the size and age of the patient, hepatic encephalopathy in a very young patient might be CRRT plus TPE, and we would do TPE daily. So we will change the CRRT circuit only when we routinely need to change it every 3 days, but we would do daily TPE, twice volume exchange, fresh frozen plasma replacement only, tandem, meaning we do it in parallel. We're using the same circuit as the CRRT circuit with centrifugal plasma exchange platform. Other centers can use plasma filtration techniques. That's also a possibility. So you could have 2 CRRT machines either in parallel or in series, and you can do simultaneous treatments with TPE and CRRT at the same time. Our center doesn't do plasma filtration. We do plasma separation and exchange using the centrifugal platform, because that's what we do for all apheresis patients. Hepatic encephalopathy stage 3 and 4 is going to be an indication for MARS preferentially. So we will consider that patient a MARS candidate. Once we correct their coagulopathy with tandem TPE treatment, we will put them on daily MARS treatments until they get a transplant if they have ALF. However, every morning, because we have to change the MARS circuit every day, we evaluate the patient every day to see if there is worsening in their coagulopathy. If there is life-threatening bleeding that we cannot control with blood product administration alone, or if we cannot stay on top of their hemostatic goals with transfusion alone, we would skip that day's MARS circuit change, we will put the patient on CRT and we'll do a tandem TPE instead. So patients get daily treatments of something augmented every day. It is intended to be MARS every day until they get transplanted, but very frequently, every 3 to 4 days, patients will need to have a reset of their coagulation. If a patient is ACLF, we'll do the same, but we'll do it for only 5 days. And we'll do it for 5 days, and we'll try and see if we can reevaluate them at the end of their 5-day course for degree of hepatic encephalopathy, for hemodynamic instability, for vasoactive infusion needs, etc. If we think that the patient has benefited but is going to need support again, we start on another 5-day course. Why 5 days, you'll ask? It's sort of arbitrary. There is some data-driven practice there. French did a multi-center study in acute liver failure using MARS in patients who were transplant candidates. It's the full MARS study. It's the only MARS study that was done in acute liver failure. And unfortunately, the study was negative because majority of the patients who were randomized to the MARS arm got transplanted because they were listed high urgency before they could actually get a MARS treatment. But of the patients who got per protocol treatment, they only had improvement in their biomarkers, hemodynamics, hepatic encephalopathy, etc., only if they had at least 3 days of treatment. So ever since we've started, we made it a rule that we were going to give minimum 3 days, ideally 5 days of treatment. That's where that sort of time course comes from. A patient who might have lower degree of hepatic encephalopathy, but has other organ failures, at least 2, will still also be considered for MARS based on a case-by-case basis. But TPE will almost always be the first augmented therapy that the patients will receive because many of them are coagulopathic, and also MARS setup is very long and requires a lot of nurses, and we typically can mobilize a nurse much quicker to do a TPE treatment even later on in the day, even at night, instead of trying to set up a MARS circuit in the middle of the night and delaying the treatment. So we err on the side of timely treatment delivery to the patient. Very typically, this ALF patient would go on CRRT within hours of admission to the ICU, would get started on TPE the next day, and would be evaluated for MARS suitability the next morning. And if we think that they are an appropriate candidate for MARS, then we will put them on the schedule for every day until they get transplanted. Very frequently, younger patients will require every other day or so treatment with TPE. So it's not a combination of which one we do. We do it all. We just don't do them all simultaneously. So it's sequential treatment, if you think about it that way, rather than all simultaneous treatment.
Yes. So is it fair to say if a patient were to be determined not to be a liver transplant candidate, is there a role for these therapies for a patient like that?
Yeah, Zach, it's a very good question. This is something that we struggle with. So when we first wrote our guidelines here, internal guidelines, we didn't have any experience in terms of utilizing advanced blood purification in CRRT patients, or liver failure patients rather, even in the case of CRRT and tandem TPE. So we wanted to be good stewards of very resource-intensive, costly, and not innocuous, potentially risky treatments. So we made it a rule that patients who were not at least potential transplant candidates would not be considered for hybrid extracorporeal therapy, including ELS. The challenge is you see patients wake up. So when you put them on ELS with hybrid extracorporeal therapy, patients who have been comatose in multiple organ failure get hemodynamic is stable, wake up, can get extubated, can actually start participating in their physical therapy, can eat by mouth. We have patients who've gone to our little patient garden here to go outside in between MARS circuits and biked and gone for ice creams, etc., all the while awaiting liver transplant. Now, granted, they were liver transplant candidates, but these were older teenagers who were redos, and it was very, very difficult. One was listed for the third transplantation. The other one was, I think both were listed for their third transplantation. So it was incredibly difficult to find the appropriate organ for them. So we knew that it was going to be very challenging to get them the organ, and technically they might die without the organ, but we still saw this intangible improvement in their quality of life. So our group struggles with this. This is a good ethical question for us. We don't really know what the right answer is at this point. Currently, we don't offer it to patients who are not transplant candidates, but maybe that rigid approach is not the right approach. So I'm thinking about it, and our group, we have a group of stakeholders who advise me on the Extracorporeal Liver Support Committee, transfusion medicine specialists, hepatologists, liver surgeons, liver ICU specialists. So it's a real life dilemma for us. Good question, don't have an answer.
Wow. Dr. Arikan, I was avoiding asking about things like that because I didn't want to be rude. I am shocked at the reversal of end organ dysfunction that you're seeing. That's like so beautiful.
So it's important to me, in my core, I think I'm always an outcomes researcher. I'll always be. I was never much of a mechanistic researcher. I do what I do because I want to improve outcomes. So I think I just want to give a better experience to our patients and have them get the best treatment from us possible. One of my fellows who then did a critical care nephrology instructor year here, who's faculty now with us, Dr. Kristen Dolan, actually looked at the functional status score of patients who were comatose with terrible hepatic encephalopathy 2 years down the line, and they have perfect functioning. Our HET survivors, hopefully that manuscript is coming out soon. I think it's under review. Maybe I shouldn't have talked about it.
We could delay publication for a few months.
Yeah. You let us know.
No. We actually have presented it as an abstract at the CRIT-AKI meeting. So some of it has been out there. So we wouldn't do this in order to create neurological morbidity, right? If we knew that treatment reversed some of the biomarkers, but didn't really actually reverse the profound CNS pathology, and the patients survived with a lot of sequelae, I think I would find it very difficult to continue to champion this as a support methodology for our patients. I know they survive with absolutely fantastic outcomes. They still need follow-up because we only know up till 2 years. We don't know beyond. So we need to keep an eye on our patients and make sure that we're not inadvertently creating other morbidity. But for now, our middle long-term outcomes have been very satisfactory.
That's amazing.
And I really want to second that chance of having a really good outcome. I mean, even the couple of years experience I've had in fellowship, we've had some really terribly ill teenagers with liver failure and cerebral edema and like focal neurologic signs, and you resuscitate them all night long, and you come back the next week for your next call and you're like, who is this? Like,
that's great.
Yeah, extubated, like either got their transplant or recovered. And there is that chance for really good survivorship, and that certainly makes this all the more important.
It is quite important to try to understand if there is a reversible cause. So we're very aggressive in terms of diagnostics. Something you alluded to, Zach, I didn't pick up on earlier on in the podcast was, could this be a bridge to diagnosis? And that is very, very important because depending on the diagnosis, we might actually be able to initiate a treatment that will protect them from transplantation, but we wouldn't have known otherwise because we would have run out of time. So it is quite important to try and understand what's driving the pathology, all of the things, all the bells and whistles. It's just to buy time.
Yes. So you've so expertly detailed a very complicated and appropriately complicated approach to managing these patients who are extremely complex. They're fragile, and you have these multiple offerings, CRRT, SPAD, we mentioned, maybe you don't do that, but extracorporeal liver support, therapeutic plasma exchange. All these therapies require such high resources, and the training and the staffing can be much more than many hospital systems can provide. How do we as physicians and really healthcare systems, how can we provide therapies to these patients? Do you see it as more like a regionalization? And how do our centers maintain experience and excellence in delivering this care to these patients?
Superb question. We have to deal with this day in, day out, especially because of our shortages, staffing shortages in our nursing, qualified expert nursing personnel, and even in physician staffing shortages. I strongly believe that a pediatric patient with acute liver failure belongs in a transplant center. I think it is crucial to get the patient to a liver transplant center as fast as possible, because it is really unrealistic to think that a moderate-sized, small-sized center can maintain competency in such a high-risk, low-frequency, complicated, resource-intensive, costly support system to do one treatment a year. It's not worth it. It's not really the right thing to do for the patients. And I wouldn't even bother trying to put a catheter in that patient, even if we know that the patient is going to require CRT. I would just ship the patient off as quickly as possible to the nearest center that we can. Having said that, many pediatric centers, especially those centers who have offered liver transplantation, should make this available. I truly believe that we have enough evidence in adults in acute liver failure to extrapolate to our older teenager population to say CRRT with high volume plasma exchange should be considered in patients close to adults in terms of age and adult patients. That requires a dedicated group of nurses who can actually do plasma exchange. Now, one way to work around it is to have a filtration-based system as opposed to a plasma exchange via a centrifugal system, which is really not any different, Zach and Alice, from a CRT setup. It's another filter. It is available on many of the common CRT platforms, and it does require hands-on training with repetitive simulation exercises in order to maintain competency, but it is at least similar machines that don't require interface with different devices from a nursing standpoint. But centers who actually have apheresis programs can easily offer CRT with centrifugal TP tandem. Periodic teaching, training, and refresher courses are helpful, we found, in our experience. We also have super users. We have a manager who is an expert in all of the extracorporeal therapies. We have a core group of apheresis nurses who do all apheresis treatments. We do cellular-based apheresis treatments as well for other patients' populations, such as sickle cell and photopheresis, etc. And TP is just an extension. It's another cartridge and another mode that they dial in the machine, so they have extreme comfort with it. But we still need to maintain a niche group of nurses who have expertise in setting up the Mars machine, taking down the Mars machine, troubleshooting the Mars machine, which sometimes is a little bit rate limiting. We will have days where we do not have a Mars certified nurse when we have to replace our augmented clearance with CRT TPE because that's all we can deliver to the patient, because we just don't have the ability to be able to set up the machine. So it does require a lot of investment. It requires a lot of recognition that these nurses are doing very special work and they need to be supported in their service and not really be taken advantage of. But it is not for every system. CRT TP can easily be done in almost all big pediatric centers. CRT TP plus ELS or MARS or SPAD probably should be limited to the centers that have enough volume, because even we don't do more than 5 MARS cases a year.
Oh, wow.
And when you have such a low frequency treatment, retention of knowledge becomes a huge problem. Thankfully, I am blessed with expert nurses who are very comfortable doing CRT, and MARS is very similar to CRT in many aspects, that they can actually teach each other and be available for troubleshooting when necessary. But the group needs to believe in it as a viable support system, and adequate support from the institution needs to be provided in order to maintain the skills that are necessary. Otherwise, it would be wasted time and inefficient treatment that is really going to end up being bad for the patients overall.
Yes.
As you move this field forward, what are the important questions that need to be answered?
Well, first of all, we don't know how to monitor the patient's response to therapy as well as we should. The younger patients will almost always be sedated and be almost, if not impossible, highly challenging to grade their encephalopathy in response to the treatment. There is a lot of theoretical biomarkers that are thought to be mediators in terms of organ dysfunction propagation. And many of the biomarkers have been shown to decrease in response to combined extracorporeal therapies like this. But we have yet to find a single biomarker, a silver bullet that can show us who is going to respond favorably, who's not going to respond favorably, who is going to have endogenous recovery with native liver, who's not going to. We don't really have the ability to be able to compare our experience to patients who are similar, who maybe are managed differently in centers that either don't have the extracorporeal therapies that we have or have different approaches. All of the evidence that I've quoted to you from the hybrid extracorporeal therapies from our center is single center evidence. Most of the evidence that I've quoted from other centers is also a single center experience. We urgently need a multi-center registry in order to really understand what the different platforms used in these patients are and how it relates to their outcomes. We cannot really do a randomized control trial here. We're not in a position to be able to do that. We need to think a little bit outside of the box and maybe have a pragmatic approach and leverage some of the comparative effectiveness research techniques and use observational therapies and boots on the ground and recognize different practices in different areas in the country, different areas in the world are to try to learn what approach is associated with best outcomes to try to control for confounding to the best of our ability. In addition, we don't really know who is going to regenerate their liver. So if there actually could be a biomarker that we could track over time that was not really cleared by any of these extracorporeal therapies, then we could say, oh, look, hepatic regeneration factor is double today. So let's give him or her one more day, and maybe we're going to be able to end this with a great outcome. We need dedicated pediatric devices. We need appropriate pediatric-sized catheters that are also pliable and not as thrombogenic as the current catheters we have. We need better anticoagulation techniques that are not citrate but regional. Sky's the limit, Alice. Really, there is so little known in this area and so much to learn in anything you can think of, really, in terms of from candidacy to trajectory to outcome to process improvement measures that you need to be put in place in order to make sure that we actually deliver the care that we think we're delivering. It's difficult to isolate one thing. If I could wish for one thing, I would say, let me have that biomarker of hepatic regeneration.
That's amazing.
Absolutely.
That's amazing. We've had a question in the past, like if you owned all the NIH dollars, what would you fund? And we want that one biomarker. Yes.
And also a pediatric friendly CRT device. That would be nice too.
That's amazing. That's amazing. Here's an empty check from PedsCrit. We've covered lots of great information, and as I've listened to our conversation today, I wish I could have had this 2 years ago, which is probably the best marker of an episode. It's something that I wish I could have learned earlier to inform how taking care of patients like these at the bedside. Question for you: if we have a fellow listening, or maybe intensivist listening, and it's really piqued their interest, where might they go for more information about this, or perhaps conferences to attend, or people to know, or things to do?
Okay, what a wonderful question. What a difficult answer I am going to have to struggle with. Liver tends to be sort of an afterthought in all extracorporeal therapies. Liver support systems typically have maybe one talk, even in dedicated extracorporeal therapy conferences. I will put a little bit of a plug in for something that we're hosting here in Houston in October of this year. It's the second summit of pediatric paracorporeal and extracorporeal therapies. This was an NIH, NICHD, our institute funded conference series. It was initially supposed to be in 2020, and then COVID did a number on us, as you will remember. And last year we had it all virtual. And even though liver was in our logo, we had no liver sessions and got oh man, got criticized so badly about it. They were right. And I'm one of the organizers, and I didn't even think of having a liver session. This year we have dedicated liver sessions, and we have one of the outstanding missions of PPETs is to bring pediatric and adult experts together. And even for our pediatric critical care fellows, listening to an adult expert is probably better in this one area of liver support, since they're going to have more experience and more expertise. So we're going to have 2 leaders from Extracorporeal Liver Support, Dean Carvelas and Oleg Zarewa, who are going to join us. Then we're going to have one of our European leaders in apheresis talk about what the gaps in apheresis are. And then we're going to have one of our junior faculty, our liver ICU instructor, talk about existing pediatric extracorporeal therapies. ALF, ACLF, does that matter? The good thing is this is free and it's hybrid. Free
Nice.
for trainees.
That's amazing.
I will send you the link for registration. And because it's hybrid, we would love it if anybody could drive down to Houston, because then they'd be potentially able to participate in the optional simulation session for extracorporeal circuits that are used in multiple configurations in terms of combinations. But if not, because a clinical service does not allow, then virtual access is possible to all talks, and they'll be available for 90 days after the meeting. So there's going to be 3 nice talks coming up. Please look out for those. PPETs in October in Houston, October 16th and 17th are the dates, and I send the link. Otherwise, pediatric extracorporeal therapies play some roles in terms of known critical care meetings. There is one dedicated AKI CRRT meeting that does have pediatric representation that happens every year in San Diego. It's the San Diego meeting every year in March, AKI CRRT meeting. And then Cincinnati, London, Stu Goldstein and Akash Deep have 3-year rotating meeting schedule, and the Cincinnati meeting and the London meeting will have specific liver support related topics. Usually, it's difficult though to find a meeting that is purely assigned to learn more about extracorporeal liver support. We did a fantastic session last year in PAS. I think it's still available online, actually. If not, I'm very happy to share my slides from that. And Akash Deep is a very good expert to look into in terms of potential talks. He is the head of King's College in the UK, who is there, obviously, the pediatric transplant center for the United Kingdom. So Akash's talks are very frequently going to be on supporting critical liver failure in the ICU. I tend to talk a lot about it, and then one of my colleagues here, Dr. Morshwar Desai, who is the head of our liver ICU, he tends to talk a lot about it. So maybe look for names rather than conferences, and then whatever's available online. FOMED is becoming a little bit more approachable for us in pediatrics as well. So hopefully it's going to be easier to get to these resources.
Yes.
Oh, yes. This is a fabulous, actionable list of items for our listeners.
Well, as we move towards the end of our conversation, gosh, we really appreciate your time today. You identified that foam is becoming even more accessible in pediatric critical care. We really appreciate your contribution to it today.
Thank you very much. It was such an honor for me to be invited, and I thoroughly enjoyed it. And I'll come back and talk about something else if you want.
Listen, you let us know. We would love to have you back.
Critical care nephrology. We're going to go talk about critical care nephrology next.
Start from the beginning.
Yep. And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscriptpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review in your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.